Hey everybody, good morning. Welcome to Poem Peeps. This morning we have sort of a special weird episode for you. We have been always doing sort of planned episodes, and we kind of thought about this idea of talking about an ICU shift in real time. And last night, both Christina and I were on overnight in the ICU, and so we thought it would be kind of cool just to talk about our nights and some things we saw and some things that we did. Christina, hope you're doing okay this morning.
Verve, yes, doing okay. And I think it's rare that both of us kind of work the same nights together, but excited to kind of go over our experiences and probably, hopefully, get some teaching points out today.
Yeah, and then hopefully go have breakfast and something.
Yes.
All right. Well, this is very off the cuff, so we hope you guys enjoy. Just for the sake of HIPAA, we're not going to mention which ICUs we were working in, and this may not have been actually the night before tonight, just to protect the identity of our patients. We may change a few details. Christina, you want to start? You want to tell me about a case that you had and some stuff that you saw?
Yeah, for so I am going to start with a middle-aged woman with hemoglobin SC disease who was initially admitted for pain crisis or vaso-occlusive crisis and admitted for IV pain management, fluids, and consideration of a simple transfusion. Her baseline hemoglobin was about is usually around 6.5, but she had a hemoglobin of 6 on admission. So she came in and was started and was doing okay for the first 48 hours. But then early morning of day 3 of her admission, she actually developed hypoxemia requiring high flow nasal cannula, altered mental status, and then subsequently required mechanical intubation and vasopressor support. And I may ask you for just kind of thinking about things right now. I know that the differential is broad, but what are some things you're thinking of right now for her?
Yeah, totally off the cuff on my 8:50 a.m. post call brain. Certainly, acute chest syndrome comes to mind with these sickle cell patients. And I always used to, hem and haw a little bit about like the simple transfusion versus exchange. The whole idea is sort of you're drowning out this hemoglobin S fraction percentage. And I think if they're only mildly elevated or they're not that sick, just a simple will work. And sometimes exchange helps you drown out a little bit more of that. But I think, acute chest syndrome would be high up on there. Certainly infection, an ARDS can happen. Same thing with sickle cell with any other patient. And then sort of progressive respiratory failure things like pulmonary embolism, common things being common, we should always sort of consider. I don't know if the patient's on anticoagulation with sickle, maybe they would have higher risk for that. There could be bleeding. So probably keep my differential broad for now as I investigated. But with these sicklers, I imagine they get treated very aggressively up front for their sickle crisis as well, given that can certainly contribute or worsen anything with hypoxemia.
You're exactly right, Firth. And I think definitely those broad differentials that you mentioned, right? Is this just a community acquired pneumonia and a vaso-occlusive crisis coming in? So, but a chest X-ray on admission show no evidence of infiltrates, but a CT when the patient decompensated, was now showing ground glass opacities, alveolar consolidation. So, a new respiratory requirement with a new infiltrate in someone with sickle cell disease and vaso-occlusive crisis, acute chest is going to be up there for sure. And exactly as you said, I think the mainstay of therapy is going to be exchange transfusion. So usually requiring a pheresis catheter where you're going to remove the blood kind of totally and then put in new donor blood to get that hemoglobin fraction down, as you said. PE definitely can be up there, as you mentioned. And then I think things can, and one of your favorites, I know in sickle cell disease, you can get pulmonary hypertension. So some of that can be exacerbated with any kind of compromise as well. But I wanted to spend some moments talking through with you and then just talking about fat embolism syndrome in hemoglobinopathies. So I feel like probably fat embolism syndrome is going to be one of those things where we see more on the board than we actually see in real life. Not sure. Have you actually seen or treated anyone with fat embolism syndrome?
No, I haven't. I mean, I've had somebody with a fat embolism before in sort of that classic, like long bone fracture type thing, but not sort of the sickle cell. And certainly have heard, prepared for it on boards, but also always want to be ready for these crazy, rare things that come into ICU. Yeah, tell me more about it.
Yeah, so fat embolism syndrome is super rare, but I kind of like to think of it as three big buckets or etiologies that can cause it. So I think a classic board question, and one that you mentioned, is going to be an orthopedic trauma. So specifically long bone fractures or pelvic fractures. So, a STEM question may be, a patient in a motor vehicle accident, is coming in with a right femur fracture and pelvic fracture, and then day 3 of admission has respiratory compromise, neurological symptoms, and a petechial rash. I think the petechial rash is not always seen, but is kind of common for fat embolism syndrome, because you can imagine respiratory distress and neurological symptoms can be from a lot of other etiologies. So orthopedic trauma is the first bucket. Non-orthopedic trauma, so specifically burns or any other injury to adipose tissues. And then the third bucket I like to think of is like non-trauma related. So two things in this category could be pancreatitis, and in our case, a hemoglobinopathy. And the underlying mechanism behind that is really bone marrow necrosis. So I think, a good type, what exactly are the manifestations and why does fat embolism cause them? So it's really the kind of the release of the fat globules into the systemic circulation. A triad, as I mentioned, being respiratory failure, which is the most common manifestation seen, neurological involvement, which is the second most common manifestation, and then the petechial rash that I mentioned. I know I've read some resources that may include thrombocytopenia. The three kind of triad that I mentioned are what you're going to commonly see.
Huh. Damn
And
fat globules. They're the
I
bane of my
know,
existence.
right? Those fat globules for sure. But really, right? So then it's like fat's released into the venous circulation and then the pulmonary circulation. But so that, thinking about that, that can explain to me, getting into the pulmonary capillaries and causing, the respiratory manifestations. But like, how exactly do neurological changes in the rash occur? And I'm not sure. Do you remember anything with that for thoughts on that?
No, I don't off the top of my head. I mean, I think that I can imagine neurologic one. I always worry about sort of paradoxical embolism if you have anything like that. So certainly unrecognized PFOs or ASDs are really common in the population. So I would definitely worry about that. But I don't remember off the top of my head the thing for petechiae, or if you don't have that, if there are other reasons why you get altered mental status.
Yeah. So nothing can pass by you, Ferb. You're exactly right. I mean, I think the most common reason for neurological manifestations is if someone had patent foramen ovale, which, as you said, is common. So common in about 25% of the population, or 1 in 4 people. So the fat can pass through the PFO, go into the arterial circulation, and then end up in the brain. And then the petechial rash, I had to look this one up as well. There's a few theories, but the like microemboli that are still able to get through into the arterial circulation that end up causing the rash. I was a little bit rusty on that last component, so did have
Yeah.
to look that up. But I think good to know. And then
Some late night pub medding. There's nothing
I
better.
know. And then another PubMed, which I couldn't remember this off the top of my head, but there's a couple of scoring systems that are used. And some of them, the major criteria are kind of the triad that we mentioned. Some other lab work, which I think is pretty non-specific, but anemia, thrombocytopenia, elevated ESR can be seen. And then one source mentioned like fat macroglobulinemia, which I'm not like, how do you even measure that? But that's another minor criteria depending on some of the scoring systems that you use. But I think perfect, as you can imagine, you and I haven't necessarily clinically seen this. It's more of a should know about it, will be tested about it. So I think, you have to have a really, really high index of suspicion if we're thinking that this is going to happen. So a bronchoscopy with the BAL may be recommended in certain cases. I think specifically if someone has respiratory distress and the patient's already intubated. So I think as part of the workup, you're going to get a CT chest, which is going to probably show some airspace consolidations. But a bronch and BAL can actually be done. And what you're looking for is, higher percentage of macrophages, but really looking for, you can ask the pathologist to look for fat in the alveolar macrophages. And both of those findings are highly suggestive of fat embolism syndrome. recommendations I know from, hematology colleagues and urology colleagues that may be consulted on patients, CT head probably is going to be, done right away, specifically if someone is having altered mental status. But really, the most sensitive test is going to be brain MRI. And there's like a specific kind of distribution that can be seen, more of a watershed distribution, signifying cerebral fat emboli. So I think pretty interesting. Some of this I remember, some of this, as you mentioned, some early PubMeding, which I think is great just to remind yourself and review. And then I think the last thing, what do we actually do for if someone has fat emboli
Yeah, right.
syndrome?
You hear emboli, you think anticoagulation, but at the same time, it's fat. It's not a clot, right? So it doesn't seem like that would have a huge impact for you. So yeah, I'm curious. What did they do for this guy?
Yeah. Overall, supportive care, and that could mean a lot of different things. But if someone is with respiratory failure, obviously doing lung protective ventilation because ARDS can manifest as well. Basis pressure support if needed. You can develop multi-organ failure, so definitely watching kidney function and other labs going along with that. In the orthopedic literature, there's some things where you want to stabilize the fracture, as we kind of talked about earlier in the case. But for people with underlying hemoglobinopathies, the red cell exchange transfusion, as we talked about, is really what's going to be helpful. There's some sparse data like on corticosteroids in orthopedic population, and then in hemoglobinopathies, some plasma exchange, but that's not commonly done. So that's kind of where I ended, right? So I think this was, for me, a good review of something that it's a rare condition, high index of suspicion to have, but specifically in someone with an underlying hemoglobinopathy, you want to keep that at the forefront. And I'm sure Rocky Nyack, who we've had on our show before, and is probably so excited that we're even bringing this up right now. So hope we're reaching out to some of the heme dream teams, as she would say.
Yeah, absolutely. For our exchange transfusion, for sure. And just to be clear on it, it sounds like you don't anticoagulate these people, right? Because it's just a fat embolism. It's nothing's going to break up from that. Yeah.
Exactly. You're exactly right, Bert.
Yeah, cool. Yeah, I mean, that's so interesting. I'm having like a fatty week, both in personal and professional life, because I just recently had a case of a patient who came in and his CT was really impressive, but he didn't look that sick, and he had fat Hounsfield unit density within his lung, consistent with potentially lipoid pneumonia, which, like you said, also a bronch for that can also show these macrophages with these big vacuoles in it. And so can be similar findings, slightly different that they'll see on histology. And it turned out that this guy was using a lot of mineral oil for constipation. So he's like the at-risk, like classic patient you hear about who accidentally is aspirating mineral oil. So that was this is a good theme with my running.
It's a good theme for the holiday season.
Yeah, yeah. Well, I had a case last night that seemed to be like straight out of our podcast. It's the case I've sort of seen before, but we've also kind of discussed before, a similar one. So I kind of just tell you in broad strokes, this patient was transferred from another hospital. She has a past medical history of some autoimmune disease on rituximab. It was actually like a myelitis that she'd been on, and probably last dose maybe 6 to 8 months ago. She had recently traveled. She had recently had COVID like about a month ago, but then came in back to the hospital initially maybe for DKA. She had a diabetes. Oh, do you hear Esme running around and meowing in the background? That's my cat. Morning. She's a morning person. So.
She wants to join.
So this patient, initially seemingly for DKA, but that got better and she's still altered, and then had progressive hypoxemic respiratory failure. CAT scan showed lots of ground glass opacity, is sort of like crazy paving pattern, distinguished areas of septal thickening with ground glass opacity scattered throughout the lungs, some areas of consolidation. Started on very broad spectrum antibiotics and antifungals and transferred over to us. And so sort of was looking at the patient, looking through everything. The infectious stuff didn't totally fit. She had already had like a bronchoscopy, and nothing was really growing. There was like a slightly positive galactomannan, thought about certainly just ARDS or fluid, but she didn't seem that fluid overloaded overall. And so DAH sort of popped into the top of my head. She didn't have a lot of hemoptysis, but it certainly looked like it could be, and she had this anemia. So I ended up bronching her again overnight. I'm curious, Christina, like how often. I feel like was a interesting decision. She's already been bronched, and so she intubated, so it's a low risk. So I don't always repeat the bronchoscopy, but curious how often you end up repeating it yourself if things are just like not getting better.
Yeah, I mean, I think as you said, definitely looking at the vet requirements and, oxygenation parameters, but I've had a low threshold, to rebronch if I think that there's an etiology that perhaps I missed, on the first time, or didn't send for a specific test, or someone's intubated for a specific reason, but they can have a subsequent insult or hit. So maybe she didn't have evidence of DAH initially, but then's developed that. So I agree, Griff. I would have a low threshold to repeat the bronch as you did.
All right, well, I feel validated. So, bronchitis patient, a lot of mucus, a lot of old blood, and pulled out a bunch of like plugs and clots. And maybe we could post a couple of these pictures I have. And then ended up doing the serial lavage that sort of we've talked about in prior episodes. And it, at least grossly, looked like the progressively bloodying sample. So, concerning to me for a DAH picture. She was also, as she mentioned, in acute oliguric renal failure. And, she was a sick lady. Obviously, we see this a lot in the ICU. Could this just be ATN or septic ATN, pre-renal initially, and then having an injury afterwards, or some other medication-induced effect? Sure, but it raised the specter of like a pulmonary renal syndrome for me. So waiting on some of the results, I didn't pull the trigger on, giving her steroids or doing like empiric pheresis for DAH. We should mention we've talked about DAH. DAH can be primary due to capillaritis and inflammation in the lungs, which you're seeing with your serial lavages is this irritation of the capillaries that continue to rupture and more blood cells will extravasate. Or it can be secondary just to infection. Now, she's not on any anticoagulation, wasn't some renal failure, so maybe some bleeding risk there. It can also be secondary due to medication side effects, toxidromes, cocaine use, things like that can also lead to this. So I was glad he did the bronch, feel like I have a good diagnosis of truly DAH. And then in my practice of this, I'm sort of waiting, maybe if she's very sick, maybe, or has like very high suspicion, or I could get a renal biopsy right away, maybe I'll pull the trigger right away. But I like to wait 12, 24 hours, see if the cultures grow anything, see if there's anything that causes me secondary, and then maybe start empiric immunosuppression. So I'll be kind of curious what comes out of it. I don't know. Have you gone to steroids right away if you get DAH, or do you usually do a little bit of workup before you pull the trigger?
Yeah, I think, as you said, I think the clinical context is going to be important, right? Someone who may be on 100% FiO2, high PEEP, and is not doing well. I may go ahead and do the bronch, and if I'm concerned or seems consistent with DAH, I may go ahead and start steroids then. If I have 12 to 24 hours, to wait, I do like to rule out, a potential invasive fungal infection before starting high dose steroids as well first.
Yeah, totally. Yeah. And the only other interesting, so I'll be curious. Hopefully I'll round back and give an update on what this patient ends up having for this. Certainly we were treating with broad spectrum antibiotics in the meantime, and sent off a slew of other workup, including serologic workup. And we've had a case of anti-GBM. So I sent that antibody to see if that was it, as well as ANCAs and sort of the more common causes of this. Somewhat interesting procedural thing with her where I do a lot of lines in ICU, work in the cath lab and stuff. So I feel comfortable with them, but it's always good to sort of talk about procedures that failed or things that happen. So we were doing dialysis catheter in her, good access, easy to the vein, confirmed on ultrasound, also confirmed on qualitative manometry, which I do for all my lines now. But, I put a little catheter over the wire. I hook up a saline filled tubing. I hold it up, make sure that it's not pulsatile, that it's dark blood, that it's draining passively back into the vein. So all that looked nice and venous, wire rethreaded, still in the vein on ultrasound. Did serial dilation, no problem. Dilators went very easily, nothing out of the ordinary. And then went to thread the catheter, met sort of resistance after like 10 or 11 centimeters of going in the catheter. So sort of far in. So it was that was a little bit weird. I'm curious if you had situations like this. I've certainly had kinked wires where you can't
Mhm.
dilate, and then you can't put the catheter through. But this sort of didn't feel like that. So I don't know. Have you had line issues like that before, Monty, and or any strategies for what to do with those?
Yeah, I mean, I think the kinked wire is going to be is kind of the most common one that I've come across. But I don't know. I feel like I have a low threshold to abort and also get another set of eyes or hands in with me just to kind of troubleshoot things. But interested to see what you ended up doing.
Yeah, I totally agree. And I think aborting, we talked about this a lot. And certainly, if anything is atypical, you don't want to force anything, right? So you got to
Yeah.
be aborting. At the same time, there's some troubleshooting techniques, some. So because I didn't think there was a king wire, I wanted to see if there was. And the dilator had gone easily. So I put the dilator back over one of the dialysis catheter dilators, and the wire was still moving so it kind of acts as a sheath, and the dilator was moving totally seamlessly in and out of the dilator. So it seems like there's not a kink there. It doesn't seem like there's a turn that's going. It dilated a little further than I had before. Same thing, catheter on, and it sort of met resistance and coil. So at this point, just as you said, I wasn't sure what's going on. I think it's something anatomic. So I aborted that line, pulled the line. The wire came out. The wire was pristine, no kinking whatsoever. Didn't have any sort of curving or coiling. So I'm not totally sure. I wonder if there's an anatomic malformation. The other thing is she had a line on the other side. Thought maybe it was making a turn, sort of going upwards, and it was just meeting resistance in that place. But I think the lesson is like troubleshoot safely. Once you have feel comfortable, but obviously always recite your line if you're having an issue. So just went femoral for her line, no issues. Dialysis catheter in with no problem, and post procedure X-ray and ultrasound had no complications from our failed attempt. But when you're doing lines and doing a lot of them, you're going to have some interesting things that you run into. You're gonna fail some of them and abort some, hopefully a small percentage, but it's good to be able to have sort of a toolkit. So I guess mine is just one, qualitative manometry, so you're in the vein using a little sheath and then measuring the pressure. And then two, if everything's going well and you feel really confident that you're not in the wrong place or causing any damage, can you use your dilator, exchange a wire, or make sure your wire is at least moving freely and doesn't have evidence of a kink for that. So always fun to do a little procedure troubleshooting at 3 or 30 in the morning.
Definitely. And I'm really interested to kind of see what's going to happen and kind of a follow up for the case. When you were initially talking about and presenting it, I'm like, oh, Mucor, like I was like, she can have Mucor, she can have aspergillus. Then you said crazy paving. I was like, oh, is it going to be, going back to like our PAP um um episode that we did. But and then I was like, yeah, then of course the episode we did with Tess where we talked about pulmonary renal syndromes, I think was definitely interesting and commonly see. So hopefully excited to get some follow up on that first.
Yeah, it was a fun diagnostic case. We'll definitely round back for all our listeners. I guess the last thing I had last night is, and this is not uncommon, unfortunately, ICU was a patient whose family ended up going comfort measures and passed away comfortably with good pain, anxiolytic control, and loved ones at the bedside. And, I think we have done a lot of talking about clinical medicine. We've had some patients on the podcast, but obviously this is a huge part of all medicine, a huge part of ICU care is sort of just our close family kind of conversations and being there for loved ones and patients in these like hard and challenging times. So just recognizing that always comes up. I thought the team I was with did a really wonderful job in supporting the family through a horrible day in their life. I think probably we should explore this further in some other episodes. We'll talk maybe about palliative care and end of life care and family communication, I hope.
Such a true point, Burp. And I feel like there's been a lot of shows either like in the movie theater, like I know spoiler alert, and then there's that show on Netflix too, From Scratch, which kind of talk about oncologic issues and end of life care. And someone was mentioning they're like, oh, like this is based on a true story, and I'm like, yeah, like we see that as providers, we see that every day. So it's just really insightful to see, and I'm glad like those cases are being exposed to the general audience and general public. And I think as a community, as you said, kind of working together and kind of thinking through how we can approach some of these end of life decisions and provide optimal care in those settings.
Yeah, yeah, and it's a skill like anything else, right? Is being knowing what to do, what you can offer, and how to do it. So it's great.
For
All
sure.
right, breakfast time. I think breakfast sandwich for me every morning. Do you have a post-call meal, Monty? Anything that you go for every time?
I'm really into lavender oat milk lattes right now, so
Oh my goodness.
I think I'm gonna try to go grab one of those.
That's awesome. I love that. All right, very cool. Much better than what my old residency post-call meal used to be, which was like a whomping Chipotle burrito. But I've moved away from those days, thankfully.
Uh, Sounds good for I'm glad that we got to share some things that we learned, and I think next time both of us end up working the same night together. Love to do this again.
Yeah, I love it. All right. Just so everybody knows, we're going to take a break for 1 week over the holidays, over that week between Christmas and New Year's. We'll post some radiology round stuff leading up to them. But otherwise, we will see you back with Home Peeps in January. Happy holidays to everybody. And stay out there taking good care of patients. All right. Have a good one.